The broadcast is now starting. All attendees are in listen-only mode.
Hi, this is Kevin Hsueh, the medical director of the MASEC program. In just a few seconds, we're going to get started with our fifth case conference. So hopefully, we've changed our tech a little bit, so hopefully this should be coming through a little bit clearer for people. Come on.
Kevin, you want to give a plug for the one-on-one interviews?
Yeah. So today, yes. So I'll get to that in just a second. Today we're going to be presenting two cases, once again drawn from real life. Disclosure, this webinar is supported by the Missouri Department of Health and Senior Services. And that this is an interactive session. So if people could log on to Poll Everywhere, that's pollev./MASEC, they can start responding to just make sure that everything is working correctly. And if people have questions that they wanted to voice out loud, just put your hand up. That's using the little GoToWebinar hands up presentation, and we'll get notified, and then we'll unmute that specific line so people can ask their questions. If people want to ask questions on an offline fashion, remember that we have the Missouri MO stewardship at worcester.edu email, single point of contact email. This is both for questions on any of the webinars, as well as we are offering a service of essentially a generalized consultation for stewardship programs to help basically programs figure out if there are any possible strategies for improving their program, for addressing issues that programs are seeing. So I'm seeing 9 responses right now, so that's pretty good. I'm going to wait till we get a couple more, and then we'll get started with this conference. Anybody else want to log in? Okay, we'll keep moving then. Why is that not working? So today's panelists is myself, Kevin Hsueh, Mike Durkin, and Erin Mockmeal. As before, just an update about our webinar scheduling. So, did I misstate this? I think I made these backwards. So we have a possible conference on AUC dosing of vancomycin on June 14th, and then another case conference on June 28th, with a conference on antibiotic allergies on July 12th, and the last case conference, at least for this season, on July 26th. We're hoping to continue our webinars after that, but we're still waiting for word on funding at the moment. So let's get started with the first case. So this is an 83-year-old woman. She has a history of Parkinson's disease, hypertension, vaginal prolapse, and not surprisingly, recurrent urinary tract infections. Oops, she does not have schizophrenia. I don't know how that got in there. She presented to the hospital for new onset confusion by her family. She was afebrile. She had a white count of 14.2, a creatinine of 1.1, a pulse of 70, a blood pressure of 100/60, and a respiratory rate of 22. Her UA was positive for Leucast and nitrites. Her culture was pending, and UA was pending at the moment. The micro was pending. Her chest X-ray showed some bibasilar haziness, but nothing spectacular. And then her UA micro came back with white blood cells too numerous to count, and she was started on IV ciprofloxacin at 400 milligrams Q12 hours empirically. So now it did that. How did that? Sorry, I'm getting a glitch here. There we go. Um, all right, so guys, I'm going to open this up. What are the issues you see with this case at the moment? Mike, Aaron?
So I think one of the easy ones that most people in this group will already identify is the IV ciprofloxacin. It sounds like they probably are treating her for a urinary tract infection, which is a reasonable presumption right now, although confusion is a little bit atypical for a urinary tract infection, at least in terms of classic symptoms. Older patients with multiple risk factors, it's hard to tease out. If she didn't have laboratory evidence that was concerning for infection, like an abnormal UA and a leukocytosis, usually I would think of confusion in an elderly patient. It's more likely being related to polypharmacy.
Right.
But with these signs being present, I think it's reasonable to treat her empirically for a urinary tract infection. I'm not sure if Cipro is the best antibiotic to manage her with at the moment. There's been a lot of warnings. We've talked a lot about them already. With Cipro in terms of drug interactions, we don't know what her other medications are, but I'd worry about that. There's black box warnings for Cipro with confusion too. Issues with tendinopathy that's worse in elderly patients, and then issues with aortic aneurysms and dissection as well.
Right.
So
I think
I would probably avoid ciprofloxacin if I could, and then the IV. If you are going to use a fluoroquinolone, they're highly bioavailable, so I would choose an oral one instead.
right. Assuming she's able to take orally, but yeah, maybe first dose IV if you really want to make sure it gets in right really fast, but then a quick oral conversion.
Yeah.
I believe, yeah, that the FDA has put out a warning saying that ciprofloxacin really shouldn't be used as first-line agent for at least uncomplicated urinary tract infections. I'm not sure if this really counts as uncomplicated, but generally, in most places, we've seen ciprofloxacin resistance of common uropathogens to be lower than desirable, really less than 80%, and you're getting to the territory where it's hard to really rely on ciprofloxacin as an empiric agent of choice. So that's one thing to watch out for. Yeah, and I also think that was it the ACP guidelines? There were new guidelines about not always treating for urinary tract infections or looking for urinary tract infections in adults who come in with new onset confusion. In this case, you have other signs that she may have an infection, as you said, the elevated white count, and of course, the lab abnormalities. There are a couple things I want to point out here. So her being afebrile, we rely a lot on fever as a sign of infection, but especially in the very elderly, and also those with uh, uh, neurologic disease. I find they can frequently not mount fevers when you would expect them to, and I also want to just point out, she has a history of hypertension, and her blood pressure is remarkably normal. That sometimes is a warning flag for people, for me, um, to just look a little deeper and make sure this patient isn't sicker than she appears to be. This her respiratory rate of 22. The problem is respiratory rate is so frequently misrecorded. Um, uh, this is slightly elevated. Aaron, did you? So how would you approach a physician here who had started somebody on IV ciprofloxacin um, for treatment of what sounds like a pretty severe urinary tract infection, if that is in case what they're treating?
I mean, I always approach the physician with just questions. So, I would ask them, just clarify what it is that they think that they're treating. And then if they do come back and say it's a UTI, I would just talk to them about, are you aware of all the risks and warnings with Cipro? Are you aware of, hopefully I would have our local susceptibility data. And so I would kind of come armed with that and just, if I'm trying to encourage possibly a switch to something else, I would just point out the risks associated with Cipro, all the black box warnings and new information for that, and then come with my susceptibility data and my antibiogram so we could talk about other alternatives.
Generally, I at least at our hospital, if a person has a relatively uncomplicated but seemingly severe urinary tract infection, I think the go-to agent has generally been ceftriaxone, IV ceftriaxone.
Kevin, that's right. I think that makes sense with our antibiogram data. Usually, E. coli is fairly susceptible to beta-lactams in the St. Louis area.
Yeah.
You have to review your antibiograms in your region, but that's what we've done for community onset ones with not a lot of antibiotic exposure.
Yeah.
We haven't gotten a lot about her previous antibiotic history or what her organisms have grown in the past for a urinary tract infection.
Yeah, and we didn't
that would
actually
play a big role with what your empiric antibiotic selection would be.
So this was just not being too specific, but this was at a institution I was at, and we didn't really have much history. She couldn't tell us, right? Because she was confused and not really able to tell us much history, except that her family said she'd had a lot of urinary tract infections in the past. But yeah, I mean, generally the break point is if it's severe, ceftriaxone. If it's not severe, then it's probably, macrobid is the agent of the first line agent of choice if you're assuming it's not a pyelonephritis. Agent pharmacology, just watch out. 400 milligrams Q12 sounds fine. But she's 83 years old with a creatinine of 1.1. That's actually a much higher creatinine or much lower GFR than you think it is. This is a common thing that's overlooked by clinicians, is that they just see the creatinine and they don't see the 83-year-old woman part of things. And just a gentle reminder is often necessary. More and more EMRs are able to actually flag that, but not all of them are not that. That's not uniformly distributed across institutions.
Kevin, chime in on the EMR, the creatinine clearance issue. A lot of people, I think, historically would have been reluctant to use macrobid for her. I think if she was coming to the hospital, I probably wouldn't start her on that empirically if she's
right,
especially leukocytosis and everything else. But if it is, it does seem to be a urinary tract infection that would be, uncomplicated. We feel the new American Geriatric Society Beers guidelines say that you can comfortably use macrobid in elderly patients with a creatinine clearance down to 30.
Yeah.
So that's different from the package insert and different from what's historically been used as a rule of thumb for providers.
And
so
if she gets,
keep in mind.
Yeah, if she gets better, I mean, I agree. You wouldn't necessarily start it off the bat, but if she gets better, it's definitely an oral de-escalation drug of choice. Because of its good tolerability and wide spectrum and relatively low penetrance in other areas. So as we stated, ciprofloxacin not really a recommended first line agent anymore. Talked about the GFR. Generally, physicians are much more receptive to warnings about insufficient breadth than they are excessively broad coverage. So I haven't generally had this problem. But yeah, I mean, just a call to the physician saying, hey, you should be aware, our hospital antibiogram suggests that ciprofloxacin may not be the best first line choice, so that you might want to choose something else. And then a suggestion of ceftriaxone is often received very well. Everybody likes ceftriaxone. And this is the thing that none of us sort of were talking about, but this patient actually meets sepsis criterion. And in fact, she actually meets more than just baseline sepsis, and we'll talk about that in a second. And she does need acute empiric treatment of her infection because of that. One thing that I wanted to bring up was a systemic issue. Sepsis is difficult to identify because it's sometimes so vague that even if you have a high level of sensitivity to it, you can miss all the elements. So some hospitals have sepsis screening programs, especially in the ED, which are called sepsis checklists sometimes. And even some hospitals implemented electronic sepsis surveillance processes, basically a program in the background of your EMR that's just constantly running to check for elements of sepsis on all the patients. This has been successful in some cases and very poorly successful in others, simply because of problems with the actual sepsis definition, as we'll talk about here. So unfortunately, I as I said, this is a real life case, and people did miss that she was septic because the elements were relatively atypical and relatively mild at the beginning. So overnight, she was noted to have essentially no urine output. And then, but otherwise be unchanged. And then in the morning, she was found on rounds to be obtunded and hypotensive to 65/30. Her pulse was 65, and the notable thing was she'd been on metoprolol, and that was probably, one of the confounding factors that made her seem less sick than she actually was. She was transferred to the ICU, where she was given, bolus fluids and brought into IV Vanco and cefepime as soon as possible. Once again, them using vancomycin, which, I'm not gonna begrudge them that in a patient who's actively crashing. But once again, if you're looking at what people often call urosepsis, it's the cefepime that probably is the more important. And we can talk about, the bolusing of vancomycin first as opposed to cefepime. The patient continued to deteriorate and was started on pressors. It was rapidly titrated to max dose levofed, epinephrine, and vasopressin. And unfortunately, she remained in refractory shock despite, max fluids, and max pressors. And she passed away within 12 hours of being transferred to the ICU. I heard about this patient in the afternoon, and then I came in and looked her up in the next day, and by then she was already essentially dying in the ICU. So this is just I wanted to bring up this case because this is a really, I thought, good example of just how straightforward sepsis can really be rapidly progressive and lead to the demise of our patients. So a question I had for the audience was, whose hospital has some kind of standard process for identifying septic patients? And that's sepsis screening, a sepsis trigger, or some sort of a thing like that. So 70, I'm going to let people answer for a bit. So this is pretty good, 88%, at least in the beginning. That might just be 3 people. So so 90%. This is really good. Does anybody want to put their hands up and talk about what they've got? Because my understanding is it's primarily this sepsis screening in the ED, because sepsis triggers are still sort of in their infancy. So the nice thing about the emergency room is it's a single point in time, and so what nurses generally are told to do is run through a little checklist of, okay, is this person breathing at greater than 20 per minute? Is this person febrile? Does this person have a white count? Are they, confused or obtunded? And then if they meet any of those criteria, they are supposed to notify an emergency room doctor so that the patient can get treated more rapidly. Sometimes even the screening process itself includes the addition of either fluids or even sometimes antibiotics. It's harder when patients are already in the hospital, which is where the sepsis triggers come in, because it's a rolling time frame. So when do you start? When is it all at once? Are they supposed to have these all on one day? Is it several days in a row? It's very confusing. And so people have run into problems with those triggers being either overly sensitive or undersensitive, missing patients that are septic, or flagging essentially every patient under the sun as septic. So any questions on the case? So that's very impressive, actually, that so many people have some kind of sepsis flag. And that's probably in part due to the SEP1 criterion. So these are CMS mandated sepsis. What did she grow? She grew E. coli, actually pan-sensitive E. coli, or no, actually it wasn't pan-sensitive. It was resistant to ciprofloxacin and Bactrim, because she'd actually had many urinary tract infections in the past, and when we finally got her records, she'd had E. coli many times. But ultimately, I don't think it was probably IV ciprofloxacin, definitely not the best choice, but it could easily have been pan-sensitive. It was less the agent and more the timing of when things went south. So I wanted to bring up sepsis because it's something that we talk about all the time, but it's always good to have a refresher on. So sepsis is undergoing a very large or multiple transformations in what people mean by the term. And what I'm going to start with is the classical definition of sepsis. This is also sometimes called sepsis 1 now, and we're up to sepsis 3 at the moment. So sepsis requires essentially two elements. One is that you have a suspected and confirmed infection. And this is one place where, honestly, sometimes physicians get a little lax on this. There are people who come in who clearly have another non-infectious syndrome, but because they meet the next thing, which is the systemic inflammatory response syndrome, or SIRS, they get treated for sepsis just because they meet that, and that's not appropriate. So SIRS requires you to meet two or more of the following. So you have to have a temperature greater than 38, or hypothermia, which is a temp less than 36 degrees C. That's 100.4 or 96.8 for us who still aren't always thinking in centigrade. Your heart rate needs to be greater than 90 beats per minute. And once again, this is 90 beats per minute without any kind of cardiac depressant. So if you're on metoprolol, this criterion should probably it's not official, but it should be lowered. Your threshold should be lower than 90 beats per minute. And your respiratory rate should be greater than 20 beats per minute, or have a PaCO2 of less than 32. And this is primarily used in the ICU, where you can actually get a PaCO2. And then have a white count of greater than 12 or less than 4, and a band count that's immature neutrophils of greater than 10%. So if you meet two or more of these criteria and have a suspected or confirmed infection, you are labeled as meeting classical sepsis criterion. So now sepsis comes in grades. You can be septic and not that sick, but then progress to severe sepsis. That's sepsis with organ dysfunction. So organ dysfunction includes many different things. Hypoperfusion, hypotension, that's probably the most classic sign, but this includes altered mental status. while this is very apparent in the young, this also applies to the elderly too, where mental status is often the first thing that changes with severe sepsis. And then, of course, you can you can go into shock from sepsis too, and that really is severe sepsis. So sepsis with an organ dysfunction. With fluid refractory hypotension. So basically, you can be dumping fluids into the person, and they still remain hypotensive. And this, this has been extended by many people to include pressors. So if the person's on a vasopressor and requires a vasopressor to maintain their blood pressure, they technically meet septic shock criterion as well. So our patient, right? So she had a suspected or confirmed infection. She had a heart rate that wasn't greater than 90 beats per minute, but she was on a rate lowering medication. She did have a respiratory rate greater than 20 beats per minute, and she had a white blood cell count greater than 12. And she had both relative hypotension. So her blood pressure at baseline was in the 150s over hundreds. And so she was significantly lower than where she normally sat at. And she had organ dysfunction, so she was altered. So this is just a refresher to make sure that whenever you see patients coming through the ED, or just patients who are newly started on antibiotics, um, have your antennas up for these possible signs, so that you can warn physicians to uh, sometimes be more aggressive than some of them can. We're caught in a catch-22, right? Antimicrobial stewards are often our goal is to have people be less aggressive than sort of they are normally want to be, but sometimes people are a little less aggressive than they should be. So um, one of so sepsis is a very highly morbid infection. So the most recent data really puts sepsis as the overall mortality for sepsis, and that includes all the higher grades of sepsis, is around 15%. That's really bad. That's if there were a community acquired infection, a single community acquired infection with a mortality rate of 15%, we would be up in arms about this. And yet, sepsis is unfortunately, one of the more common diagnoses of people coming into the hospital. Severe sepsis has a mortality that's much higher, 25%. That's 1 in 4 patients die within, I think, 30 days of severe sepsis. And then septic shock has a mortality of equal to or greater than 40%. So this is 1 in 2 people never survives septic shock. And that is pretty apparent when you look into the ICUs. Um, so um, a reminder: antibiotics are probably the number one intervention to reduce the mortality of sepsis. So, this is a classic study from Kumar et al. In Critical Care Medicine, which was published in 2006, looking at septic shock patients. So patients who were hypotensive and had all the signs and symptoms of sepsis. And for every hour delayed um, uh, of antibiotics. So for every hour that antibiotics were delayed in these patients, mortality basically went up by double. So at essentially at 36 hours, these patients essentially almost inevitably died. There is some confounding to this, but it's a pretty this is data that's been repeated and shown to be pretty consistent. So when you have a patient,
that's a great point, Kevin. This also, just to remind you, this scale is on a log scale too, so it's not linear.
yeah,
So
that's the doubling. It looks like it's going up by sort of in a line, but that's this in a normal scale, it would be like this. It'd just be way passing the top of the bar. So
the other thing too, I think to emphasize too, is this is one of the settings where if patients are septic, I don't usually try to push antibiotic stewardship in these settings as strongly, because getting the antibiotic selection wrong to begin with can sometimes have adverse events and can also be problematic for developing trust with your clinicians as well. So obviously you want to still practice stewardship, but in settings where they're really sick, if they want to use broad spectrum antibiotics, I'd emphasize narrowing them when you've got the cultures back or when they're stabilizing rather than when they're sick.
Well,
Really
I would push back against that and say that this actually recommending a broader agent or more appropriate agents is stewardship. So if you see when you're rounding on or chart rounding on your patients, you see somebody who probably meets the definition of sepsis, but isn't on broader agents or isn't on agents that would cover, a sepsis or severe sepsis. Calling the physician and reminding them, hey, this patient, meets all the criterion for sepsis. You should probably broaden coverage if you're not, if you're not already thinking of that already. That I think, I would pose that actually is antimicrobial stewardship. Remember, the goal of antimicrobial stewardship is to make sure that patients get the most appropriate agents for the amount of time that they need to. And I would argue that is, a recommendation of appropriate agents.
It's a good
So
point, Kevin.
However, going along that theme, there are a lot of non-infectious mimics to sepsis, or to so all of these, and I could keep going with these. This is just a very small list. Can mimic sepsis. So, inflammatory bowel disease, your white count can be very high. You can have hypotension just because of the massive amount of diarrhea that you're having. Of course, if they're dehydrated or have a gunshot wound, they'll have they'll meet all the SIRS criterion, medication side effects and overdoses, basically anything, including MIs and pancreatitis, or sterile pancreatitis, heart failure, small bowel obstruction, diabetes, lupus, and lots of other rheumatoid diseases. So they can all mimic sepsis, and this is, remember, sepsis, or at least they can fulfill the SIRS criterion, but of course they don't have necessarily infection. And so what this really I wanted to point out was the importance of the antimicrobial timeout. So the importance of revisiting antimicrobial decisions after the diagnostic and therapeutic decisions have been started and had some time to work themselves out. So have the providers, remind the providers that they need to revisit their antimicrobial decisions at regular intervals. And oftentimes when I call physicians to recommend, sepsis therapy, I tell them, just a reminder, at 48 hours, take a look at this patient again and see whether or not they really need these broad spectrum antibiotics. And honestly, especially in the ED, they're very receptive to that because it's not them that's actually revisiting it. But oftentimes we find that, the patient's having an MI, they have pancreatitis, they're having a heart failure exacerbation, and that's why they appear septic. And so if a non-infectious diagnosis is established, as the primary diagnosis, that's a time to revisit this with the providers, and recommend, de-escalation at a start at least, or ideally discontinuation if there really is no infectious process going on. There are a couple of studies that are looking at this, whether or not this is this can be formalized as a practice, but generally it's a good recommendation to providers. So I'm going to ask how often people see providers continue antibiotics for quote unquote sepsis, even though they've identified a non-infectious cause. And I will say my answer probably lies right there some of the time. You know, with the push to get people out of the hospital faster and faster and faster, I think this has changed from most of the time to some of the time, because the IV antibiotics, honestly, they hold people in the hospital. And so I think providers are getting a little bit more comfortable stopping antibiotics just because they're being pushed to get these people out the door. If you have a heart failure exacerbation and you're diuresing that patient, once you get them even sort of stable, the push is to get them out of the door. So you don't want to have them on antibiotics at the same time. So most people are saying some of the time, some of most of the time. So that goes along with, I think, my experience. This has to do with the providers, though. I think trainees are often more inclined to go to the all the time or most of the time, while more experienced physicians probably lean towards the summertime. Interesting that it's rarely or never. So that speaks to the need for antibiotic timeouts, sometimes formalized. All right, let's go to case 2. So this is a 67-year-old male. He had a history of obesity, osteoarthritis, and a recent right total knee replacement. It was about a month ago. He presented to the ED because of worsening swelling, pain, and redness of his right knee for 5 days. So he was initially given Keflex at 500 milligrams TID for cellulitis. He returned 2 days later with worsening swelling, and the exam showed a gross effusion of the right knee with an aspirate, which showed a white count of more than 100,000, red blood cell count of more than 500,000. So vital signs were stable. He had a normal white blood cell count and creatinine, and was started on IV vancomycin and cefepime, brought to the OR for INDs, and the OR cultures grew Corynebacterium striatum. The patient was switched to daptomycin as he developed Redmans with the vancomycin, or he at least had it once. And then, that actually was the trigger for our stewardship program to take a look at him, because he was daptomycin is one of our trigger antibiotics. What stewardship do people see? Stewardship issue do people see here? And I'm going to open this up to as many people as possible. So, Aaron, Mike, what do you guys see here? And how would you approach this case?
Yeah, so Kevin, I think this is a great case. This is very classic for what we see at our institution. A lot of times the orthopedic surgeons will put patients on antibiotics when they suspect that there's a prosthetic joint infection, but they're not quite sure, and they're hoping that they can get away with treating them for cellulitis alone. It sounds like they, eventually they did the right thing, and fortunately the cultures weren't inhibited too much by the antibiotics with cephalexin beforehand. Sometimes we have issues with empiric antibiotic selection, increasing our risk of having culture negative infections down the road. So we've been fortunate with that. The empiric antibiotics that they put him on, vanc and cefepime, are standard at our institution for this. The Corynebacterium striatum, really the antibiotic of choice that we like to use is vancomycin for this. It's unfortunately that he developed Redman syndrome. I would try to tease out more information about the Redman syndrome allergy. A lot of those can be overcome by changing the infusion of vancomycin. Some of them, when you ask them, aren't even related to vanc at all, or maybe related to other medications or flushing from something else.
Or sometimes people just set the pump wrong, right? So what's interesting is usually Redmans isn't something that develops over the course of therapy. It just starts at the very beginning. At least in my experience, that's generally what it's been like. So somebody who develops, new onset Redmans is a kind of odd issue, and I'd actually look at maybe was the infusion pump set wrong, or maybe did they just try to push it in because they were rushing for one reason or another. But yeah, exactly. So before switching to Dapto, which is an expensive agent, try all the alternatives to make the Vanco actually work.
There's one other downside with using daptomycin in this setting too. I don't think our institutions publish this, but we have internal data that Corynebacterium striatum can rapidly develop resistance to daptomycin too. So among the ID physicians, we try to avoid using daptomycin if we're going to treat a Corynebacterium infection that's for a prolonged period of time, or that we think would be challenging to eradicate. And a prosthetic joint infection where you're going to be giving them 6 weeks of Dapto, I'd be very worried about giving this patient dapto-resistant Corynebacterium infection. So
Darn,
I probably try to put him back on vancomycin if possible after I tease out the red man syndrome intolerance issues and talk to the nurses and the patient and probably the other providers about changing the infusion rate for the bank.
you caught my trick. So yeah, I was using this case to bring up the potential complications of using daptomycin with Corynebacterium striatum. So about this particular bacterium, Corynebacterium striatum. So we've been seeing this pop up more and more with prosthetic joint infections. It's not a particularly aggressive organism in that it doesn't cause infections that rapidly progress or are very invasive. But the unfortunate thing is the Corynebacterium is a hardy bug, and it often has multiple resistances. So sometimes this Corynebacterium striatum is sensitive to beta-lactams, but honestly, in my experience, most of them are not anymore. Some of them are nearly can be nearly pan-resistant. They're almost always uniformly sensitive to vancomycin, but sometimes vancomycin is not an option for people. And they can be resistant to daptomycin. They can be resistant to all beta-lactams. They can be resistant to doxycycline and other tetracyclines, which means that you have no options for oral therapy. They're resistant to Bactrim too. So this is a problematic bug, and just from experience in prosthetic joint infections, it can be very difficult to eradicate, even after appropriate source control. So an IND or an explantation, sometimes this bug can even persist after that. So yeah, I mean, one thing that I wanted to point out was they started IV vancomycin and cefepime before they brought him to the operating room, and in this case they started him a day or two before they brought him to the operating room, and we were really lucky that the Corynebacterium still grew out. This is one thing that if you have orthopedic surgeries done in your hospitals, you may want to talk with the orthopedic surgeons or the emergency room to make sure that for stable patients, so he had a normal white blood cell count, he had a normal creatinine, normal vital signs. For stable patients, you don't want them starting empiric antibiotics very early at all. Usually we tell them to start it in the operating room if necessary, but really try not to start empiric antibiotics unless they absolutely have to, because if you lose your organism, it's essentially a roll of the dice then whether or not you even know what you're treating. And these are complex multi-stage infection treatments that really require knowledge of the organism is incredibly helpful for long-term treatment of a prosthetic joint infection. So you really want to get them to shy away from this practice. In other institutions I've been to, we basically had an algorithm sheet, basically a protocol sheet for the emergency room on how to approach bone and joint infections, which included prosthetic joint infections, which was basically hold off unless the patient is actively systemically ill. And if they're febrile or hypotensive or have a spreading infection, absolutely give them antibiotics. But if it's just like an ulcer or a single swollen joint, I wouldn't necessarily until you know what you're treating. Get a culture. Other thing is get a culture with your aspirates. So in this case, they didn't. They just aspirated the joint, and they didn't send it for culture. That's a missed opportunity there. So especially with high volume services, you're going to want to give them guidelines because honestly, it's helpful for them and it's helpful for you. And then there's the whole cellulitis thing, and notably, I find it interesting that nobody pointed out that Keflex 500 TID in a person with normal renal function is generally too low for cellulitis. It should be QID really if you're thinking of streptococcal cellulitis. But nobody likes that because 4 times a day medications are really difficult to take. But the pharmacology of Keflex means that really 500 QID really for a significant infection is where you want to stand at. So I think we went through all the issues. One thing to point out was cefepime probably is not needed if you have a single prosthetic joint organism, and they continued him on cefepime and daptomycin at the same time. And then in this case, the patient was discharged on cefepime and daptomycin for 6 weeks, and then came back 2 weeks later with persistent pain and drainage from the incision line. The surgeons just thought that the joint itself was, or the repair itself was failing, and so they explanted it. But the OR cultures actually grew a daptomycin-resistant Corynebacterium striatum, which was still vanco-sensitive, interestingly, which suggests that it's a different mechanism than what we see with daptomycin resistance in MRSA. Then the patient was actually switched back to vanco with prolonged infusion and diphenhydramine pre-medication, and he did fine, though he had an explanted joint. So any questions on this case? I'll come back to this because I want to talk about the teaching points for this. So we actually did, WashU did publish that study, but it was really a very small case report. So what they saw was, and this is primarily in LVAD patients with persistent Corynebacterium infections in their drive lines. They found that after daptomycin therapy for a couple of weeks, there was rapid development of daptomycin resistance from 0.064 to greater than 255. So this is major upregulation of resistance. And what they really found was that there was a binding protein that is used by daptomycin to get into the proper area of the cell that the cell had deregulated or dysregulated. So daptomycin previously bound to this protein, and then with the as the bacteria got more resistant, that protein was being downregulated, and that's probably why daptomycin wasn't working in these patients, while vancomycin still would. And the teaching point for this case is really that there are certain circumstances where you have to be very worried about development of resistance on therapy, or, even appropriate therapy, or apparently appropriate therapy. So the situations where I get very worried about this are any intense infections with insufficient source control. So, and I think we've all seen these cases, large abscesses where no one wants to touch them, but the patient's on antibiotics for them for very long periods of time. Skin and soft tissue infections with multiple abscesses, any bone infections, endocarditis, things like that. So if there's insufficient source control, be very worried about it. And this is something that we have to keep reminding the providers, that antibiotic therapy is not the only therapy for infections. That source control, physical debridement and physical removal of infected material is part and parcel of your treatment of antibiotic or of infections. So when they treat bacterial colonization, and we've all seen this, so Foley catheters that are colonized, if they treat that bacterial colonization, you're going to get resistance, and often very quickly. So within 1 or 2 rounds of antibiotic therapy. Organisms that have inducible antibiotic resistance. So that's Staph aureus and inducible clindamycin resistance, and this is the reason they do the D-test. Organisms with AMP-C beta-lactamases, and those are the SPACE MP, sometimes called SPICE organisms. That's Serratia, Pseudomonas, Acinetobacter, Citrobacter, Enterobacter, Morganella, and Proteus/Providencia. So these are organisms where you have to be much more worried about development of beta-lactam resistance on therapy. And these are all beta-lactams up through ceftriaxone. So cefepime uh, shouldn't get resistant like this, but it can with especially some of the more hardy bugs like Acinetobacter or Pseudomonas. Um, but carbapenems are generally the agents of choice in with these organisms. Um, then there are organisms that can be heteroresistant. So that means that part of the population, overall population of the organism can be resistant. So one of these situations is heteroresistant vancomycin intermediate Staph aureus. That's sometimes termed H. visa, where you have Staph aureus, it appears vancomycin sensitive, and then as you treat, you start to develop vancomycin intermediacy. That's probably due to heteroresistant visa. And then oxacillin heteroresistance of Staph epidermidis. So this is just a warning. Staph epi can be a small percentage of the baseline population can be oxacillin resistant, and that just comes out as you treat with oxacillin. So be very careful about just assuming that the sensitivities for Staph epi are oxacillin sensitive. This is why vancomycin is generally the agent of choice for Staph epi and not oxacillin, even in the context of proper testing. I know there's a lot of debate about this one in particular, or actually there's debate about all of these, but there's a lot of debate about this. And then any bacteria that grows very, very slowly is at high risk for resistance developing on therapy. And this is Mycobacterium tuberculosis, atypical mycobacteria. This is the reason why we have to use so many drugs all at the same time, is that they're usually very, very intense infections, and also the slow growth of the bacteria means the slow death of the bacteria with antibiotics, and therefore that they persist in larger populations for longer periods of time and can develop resistance while on therapy. So these are just anytime you see especially atypical mycobacteria. So MTB, it's pretty clear. Use RIPE therapy or another combination therapy. Atypical mycobacteria, though, people are less aware of how to treat these, and so if you see an atypical mycobacteria and you're looking at the treatment regimen, unless it's a really clearly uncomplicated, very small infection, and if you only see one agent, be very, very careful about that and question the provider about whether or not they've double checked that this shouldn't be treated with multiple agents, because these can be disastrous because they develop resistance very, very quickly or relatively quickly, and can become essentially untreatable in certain situations. So one question I wanted to bring up was whether or not people's labs automatically labeled all of the space MP, that's like Serratia and Enterobacter, organisms resistant to first and third generation cephalosporins. This is something that our lab does, but I've seen quite a few other labs that don't. And there is a very significant debate in the microbiology world whether or not this should happen, because from a stewardship perspective, if you could use a first to third generation cephalosporin, that would probably be better. But the worry is that these are chromosomal inducible beta lactamases. There's no real way to test for them unless you're retesting that particular infection, which almost never happens. So our lab has essentially decided that the risk of undertreatment or treatment developing on therapy is higher than the possibility of people using lower tier antibiotics for infections that could get them. I hope that made sense. Honestly, looking at their data, that I agree with them. That there's no way for labs to tell for all these organisms whether or not the organism is sensitive, not in a straightforward fashion. So this may be something that you want to talk to your lab director about if you have a in-house or single source lab. There are many hospitals that don't, that send out tests to commercial providers, and unfortunately, I think Quest doesn't do anything of this nature, Quest or some of the other commercial providers. So something to talk about if you have a amenable microlab director. So at this point, I wanted to open up the case conference for any volunteer cases or any questions about either this case conference or questions from previous conferences that people had brought up. And remember that you can also just send us an email on the mostewardship@worcester.edu central point contact email, and we'll respond. We've gotten a lot of questions about um, the AUR module, how to use it, about specific kinds of cases. So if anybody, raise your hands or throw something down, we're happy to hear from you. All right, I'm going to come. So we're actually reaching the end of the hour, so I'm going to probably close this and end the session in just a little bit. No questions? All right, if people do, then please just send them to our Most Stewardship email, especially if people have cases they'd like to have discussed. We're very happy to bring up cases from our participant hospitals. So as I said, questions to Most Stewardship. I thank you all for attending, and I will see you next time. The next case conference is 6/14. Or no, that's not the case conference. The next webinar is 6/14/2019. If people could send back conference feedback, that would be very helpful. So hopefully this continues to be a useful resource. If not, please leave your comments. Or if so, please leave your comments. And we'll see you guys next time. Thanks very much. Signing off. It's really not like audience participation is really declining.
Yeah, I don't know.
I don't know either. I'm trying to figure out what we can do to make things less didactic.
Even in the case conferences, they're still not participating that much. 15 people were there.
Yeah, I mean, the volume is at least stable, so it's not like we continue to decline. But we haven't sent out more marketing. So
yeah. Well, I don't know if they want shorter. Is an hour too long?
Could be. Could just be, could be that they just want a short, brief session. I mean, or they could want no sessions at all. That's not great. Let me think about that.
Well, we still need to analyze all the surveys.
Yeah.
That people are doing.
Yeah.
You get one of Ginger's people on that.
Let me send that out. I just have to pull it from the webinar.
Freezing. And I appear to have probably either like a mustard or cheese stain on my shirt, so I'm gonna wear a white coat while these patients survive. Right there.
It happens. Are you sick?
No, I'm fine.
All right.
Good job, Kevin.
Yeah. Well, we'll see. Let's see if there's any interest on getting an AQR.
I hope people will find it valuable.
Yeah.